or related to the coronary artery disease and its presentations. It could be in the form of angina, it could be in the form of heart failure, it could be in the form of arrhythmias, it could be in the form of a variety of conditions in combination with hypertension, diabetes, renal problem, pregnancy, just to name a few. So we need to understand how do we deal with these patients when they present with progressively worsening symptoms, or if they are unstable, or point blank they present to the emergency room with a STEMI. Every one of these aspects are going to be covered in this 2021 ACC AHA guidelines. Please grab a cup of coffee, sit down and relax, because this is something, as a primary cardiologist, we all need to understand whether we like it or not. Because if you are a new fellow starting, or if you are a fellow taking cardiology boards, these class indications for various procedures and interventions are of paramount importance in terms of knowing what is the indication, what is a contraindication, what is useful, what is harmful, and how do you navigate through a myriad of conditions related to patients' cultural diversity, their likings and dislikes, their symptom presentation, their cardiovascular status, their coronary anatomy, their other risk factors. So it is an entire ocean as far as coronary artery disease is concerned, but this is what we are going to be dealing for 95% of the time in our practice. As I said, I've been in practice for 40 years. Most of the time we are dealing with patients with coronary artery disease or chest pain or cardiac evaluation for pre-op clearance. All of these fall into the same category as how do we approach these patients in terms of diagnosing what is the problem. Do they have coronary artery disease? What is the extent of coronary ischemia? And what is the status of their left ventricular function? What are their comorbid conditions? And a whole host of things. So let us begin with the real presentation. And of course, in the past, when I started 40 years ago, it used to be, Mr. Smith, you have a blockage in the artery, you're going to need a stent placement, we're going to set you up for the test tomorrow. And that would have been more than adequate. But today, with the patient's access to the medical information through various social media and friends, these patients are extremely involved in their management of their cardiovascular problems, and that is something we as physicians have to become accustomed to, incorporating the patient, the family, into the decision-making process. So it is no longer, I'm the specialist, I'm making the decision, and this is what you need. Well, forget it. Those days are gone. Here it is a shared decision. You explain to the patient what the underlying problem is. What are the challenges that you face in terms of anatomy, calcification, a whole host of other risk factors like hypertension, diabetes, renal failure, arrhythmias. And then you make an intelligent decision. And when we are making these decisions, we always have to discuss the alternative treatments, which is very often ignored in the medical profession. And I can tell you that from experience. Most people will come and say, well, I don't think, the other options are really good. They don't even explain what they are. So just keep that in mind as a new physician, or if you're starting cardiology training, you need to get your patients incorporated in the decision making and try to explain to them as clearly as possible, as much as you understand, so that they can make an intelligent decision. Again, cardiovascular problems have become extremely complex. Previously, we treated them with medications, risk factor modifications, exercise, diet, weight reduction, blood sugar control, high blood pressure control, but those are the foundations of managing cardiovascular patients for the rest of their lives. But when it comes to more diagnostic tests, which have become extremely complex and so many different varieties, from echocardiography, stress tests, CT scan, nuclear scan, MRA, PET, and then we have instruments to look for arteries inside the coronary lumen. So it becomes a team effort between the cardiologist, the patient, the cardiovascular surgeon, and the social worker, and also psychological evaluation of these patients. All of these need to be taken into consideration because the outcomes may not be always what we expect it to be, and unless we discuss all these things, it may not come across appropriate, and the patients may feel sort of, they were not given all the proper information to begin with. Keep that in mind, because the whole thing has to be patient-centered and patient-focused. We are there to serve the patient, and we have to answer every one of their questions, every concern, and then use the medical knowledge to tell them, okay, this is what we think is based on the guidelines, and this is what we recommend, and there are alternatives to that too. Okay, when it comes to decision making, there are a lot of things that are involved. As I said, with cultural diversity, we have the complexity of communication and cultural preferences. Along with that, so it is very important not only to understand their coronary anatomy, their functional status of their left ventricle, but we also need to do a psychological evaluation of the person we are talking to or the person we are dealing with, because if we don't understand the patient, we won't be able to serve them in a meaningful manner. So these are some of the things that you may want to make a note of that while you're trying to understand the patient from their perspective. Okay, and here are some other things that, here are some other things that we need to keep in mind. The language is an issue, especially if we are coming from different ethnic backgrounds. Then we have to use evidence-based data to support whatever that we are recommending. Should give time for patients to ask questions and answer all their concerns before we proceed with the procedure. All right, so the next point is, let's say we feel this patient has progressive symptoms, this patient needs some kind of an intervention because the medications are doing all right, but they are not enough. The patient is having progressive chest pain, so you do a diagnostic test and then you decide this patient needs a procedure. The question is, what kind of procedure is this? Is this an elective procedure? Is it something that can wait for a few weeks? Because there are some patients who have sort of a chronic stable angina with mild increase in their symptoms, but there may be other things preventing them from having the procedure, and can they wait? And urgent is where a patient is going to need an intervention, perhaps during that hospitalization because of changing clinical condition. Someone comes with a vague chest pain, then we realize you're planning to do a stress test. Later on, you find out they have a positive enzymes and the chest pain is getting worse. So obviously, you have to change your course of how you're going to deal with this patient. That's why every minute to minute following these patients, based upon their presentation, changing clinical findings is of paramount importance in trying to fine tune as what they need at that moment. Emergency surgeries are you're familiar with, like an appendix, or someone comes with a myocardial infarction with a complication like papillary muscle dysfunction, ventricular septal defect. So these are all emergency procedures which you don't have much time. You just have to gather whatever information you can, do the procedure, and once they are back, then you try to put all the pieces together. And there are certain situations where salvaging, like we try to do an intervention, coronary stent, the procedure fails, then in order to salvage the patient, we may have to take them for surgery. Again, that depends upon what is their left ventricular function, how much of the myocardium is at risk, what is the age of the patient, what are the comorbid conditions. So all of these things have to be pre-documented in order to make a meaningful decision. And as I said, document everything that you do with the patients. What is not documented is something that you never had a conversation with your patient. That's where a lot of times people get into a problem. because when they are recommending emergency surgery or an urgent surgery, the indications are not properly documented. And if you don't document it, or if you tell them, okay, you can wait for the procedure and not give proper instructions that, well, if you're having worsening symptoms, you need to come back to the emergency room. Otherwise, the conditions can change. So documenting what we tell the patients and what we advise is of paramount importance in terms of educating the patient, but also protecting ourselves that we have done what our duty is. Okay, the next thing we want to talk about is these practice guidelines are based on research studies, some of which are randomized, some of which are meta-analysis, some of which are non-randomized, and some of them are based on expert opinions. However, as a clinician, or if you are a fellow studying this for the first time or studying for a board exam, this is extremely important because there may be several questions on the guideline indications for a given procedure, or what are the contraindications for doing certain procedures based on the practice guidelines. And we're going to talk about that now. Class 1 is a strong indication where the benefit far outweighs the risk. Just remember the top lines here, And it has been substantiated by randomized clinical trials. It has been substantiated by meta-analysis, things like that. That is as far as the class is concerned. Then we have levels. What level of support we have in terms of recommending this? Well, if it's a randomized clinical trial, then it is BR, that is randomized clinical trial. And these are all randomized clinical trials, high quality, large scale randomized trials. Then we have a non-randomized trials, which are of moderate use, but meta-analysis may be useful in looking at the direction of the treatment modality or the medication. So here I put together, there are a couple other things. Class 2A is moderate indication. Benefits more than the risk, but not compared to Class A. So Class 2A is acceptable, and you just want to make sure that the data is there to support it in terms of randomized clinical trials. There are other types of clinical studies like limited data based upon and then the expert opinion. Okay, let's move on. Here, Class 2B is a weak indication. It's plus or minus. So this is something you have to keep in mind. As far as you are concerned from a practical point of view, Class 1A, you need to know in every category what is Class 1A indication. And you need to know Class 2A indication in most of these categories, whether they're going for a balloon angioplasty or a bare metal stent or a drug-eluting stent or coronary artery bypass surgery or ventricular septal repair. We need to know what is Class 1A indication. And then finally, we need to know what is Class 3 harmful, something that is not recommended by the practice guidelines. So those are the three things I would focus upon: Class 1A, Class 2A, and then Class 3, which is harmful. As you can see, Class 3 is harmful, where the risk outweighs any benefit from the procedure, be it coronary intervention or coronary artery bypass surgery. Then we have to look at the coronary anatomy, because if you're going to take someone for the cardiac catheterization lab and plan on coronary intervention, we need to understand the coronary anatomy. Coronary anatomy is not a homogeneous substrate. There are many things that vary depending upon the complexity of the disease, multiple risk factors, age, calcification, tortuosity, and a whole bunch of things, bifurcation lesions, and also pre-existing other concomitant conditions like aortic stenosis, mitral regurgitation, or there could be a thrombus. Or if you're dealing with a saphenous vein grafts, you may be having all this cheesy material, which basically just goes downstream and create multiple showers of emboli into the distal segment of the vein graft. So all these things are of importance. Then we need to look at procedural factors. Access to PCI. Do we have a hospital where you can readily do the PCI as and when it is needed on an emergency, on a STEMI patient? What are the surgical risks? What are the PCI risks? Unstable presentation in a shock or cardiogenic severe heart failure, and is the patient severely hypotensive? Can these patients tolerate dual anti-platelet therapy? All these things have to be documented, and then we will be able to decide. In patients with angina or angina equivalent, undocumented ischemia and angiographically intermediate stenosis. So you're doing a cardiac catheterization, you see like a 50-60% lesion, but it looks kind of raggedy, and you're not sure what is going on here. But in those situations, to determine if this artery stenosis is significant functionally, we are talking about functionally, we looked at the anatomy, now we're talking about functionality, then it is reasonable, class 1A indication, to do fractional flow reserve or instantaneous wave-free ratio, IFR. So these are the procedures that can be done in the cath lab to further delineate who is going to benefit from the intervention and who is not going to benefit from the information. Okay, along the same lines, if we do the FFR, in the FFR is greater than 80 or IFR is greater than 89, then this is a contraindication to do the procedure, and PCI should not be performed, because if you do, first of all, you're not following the guidelines. Number two, if you harm the patient, somebody's going to come after you. So you want to practice guideline-directed medical therapy or interventions, and you have to have evidence to back up anything and everything you do. All right, let's keep moving. And of course, when we have patients with multiple coronary artery disease, multiple segments within the coronary arteries, it is reasonable to get the syntax score, which will tell us how the patient may perform following the procedure and during the procedure. This is a class 2B. It's a little bit weak, but it's still useful. As you can see, class 2B, it's weak. And class 2A, in patients with intermediate stenosis of left main coronary artery disease, IVUS is a reasonable option to look at the anatomy of the left main, look at the plaque structure, look at the evidence of any calcium, look at the irregularity of the lumen, and see if it is feasible for a stent placement. Again, this is 2A, and this is non-randomized trials. Okay, let's keep moving. Now going to talk about STEMI. I mean, it's pretty obvious. I'm not going to just emphasize the same thing which all of us know. It is a class 1 indication. If someone has a STEMI and symptoms for less than 12 hours, it is reasonable to do a PCI. If someone has a STEMI who is hemodynamically unstable, PCI or CABG is not feasible to improve their survival time. In patients with STEMI and cardiogenic shock or hemodynamic instability, PCI or CABG, when PCI is not feasible, is indicated to improve the survival. So in other words, if we can do a PCI in a patient who has STEMI, cardiogenic shock, some complications, CABG may be the best alternative. Then we have the next indication, STEMI who have mechanical complications like ventricular septal defect, papillary muscle dysfunction, papillary muscle rupture, or severe mitral regurgitation. And these patients do best. The outcomes are extremely bad, but they do better with coronary artery bypass surgery and perhaps fixing some of these leaks. Another class 1 indication, but this is limited data, in patients with STEMI and evidence of failed reperfusion fibrinolytic therapy. So if we gave a fibrinolytic therapy, it initially opened up, then the artery closed up again, there are new symptoms, and what do? I guess it's a class 1 indication to go to the cath lab and see if we can reopen the artery and put a stent and reestablish the circulation. Next, we are continuing with the STEMI in patients. Okay, here are class 2A indications, which are also reasonable, I would say. In patients with STEMI who are stable and presenting 12 to 24 hours after symptom onset. In patients with STEMI who are stable, who present between 12 and 24 hours after the symptom onset, PCI is reasonable to improve the outcomes. Again, it depends upon, are we looking at a small PDA branch, or are we looking at a diagonal branch, or are we looking at a proximal LAD? Same thing, in patients with STEMI in whom PCI is not feasible or successful, and if there's a large area of myocardium involved, then an urgent coronary artery bypass surgery is a reasonable alternative. So if somebody has PCI and they are not successful, and if let's say this is an LAD lesion and it involves a large area of the myocardium, then I think it is reasonable to do the coronary artery bypass surgery in that patient to improve the myocardial perfusion, improve the left ventricular function, and perhaps maybe alter the long-term prognosis. In patients with complicated ongoing ischemia or acute heart failure, life-threatening arrhythmias, PCI can be beneficial to improve outcomes irrespective of the time of the onset of MI. So let's underscore this. So you have a patient there 48 hours post MI who has been transferred from another hospital. Now is having pain, heart failure, arrhythmias, and it is reasonable to do a PCI in these patients. Let us continue here. STEMI core 3, things that you don't want to do even in a STEMI patient. In asymptomatic stable patient with a STEMI who has a totally occluded artery greater than 24 hours after the symptom onset. So the patient comes to you 24 hours after an MI, maybe he's transferred from a different hospital. You do a cardiac catheterization, you got a total occlusion, CTO of the artery, then they say PCI should not be performed as an urgent procedure. Things need to be evaluated, look at the amount of myocardial tissue in jeopardy through nuclear test or PET, and then decide, because CTO is a long procedure and they certainly don't want to do that in the presence of an acute myocardial infarction. Again, number 3, harm. In patients with STEMI, emergency CABG should not be performed after failed primary PCI in the absence of large area of myocardial ischemia. Again, as I said, if you're trying to do a PCI to like a diagonal or a posterior or descending branch or one marginal, I don't think that patient should be going for coronary artery bypass surgery unless they have severe triple vessel disease, which is a different setup altogether. So to summarize the whole STEMI, this chart puts the whole thing together. So let's say we're dealing with a STEMI patient with ischemic symptoms who comes to the hospital with chest pain, got EKG changes, has ongoing symptoms. The symptoms are less than 12 hours. PCI is feasible. Let's do the PCI. It's class 1 indication. While the PCI is not feasible, the large area of myocardium, we are talking about 20-30% of the myocardium is at risk, then consider CABG, which is 2A indication. Now let's get to the other side. Symptoms are greater than 12 hours. Now this is symptoms more than 12 hours. So there's no urgency in terms of rushing them to the cardiac catheterization lab. Unless they have a cardiogenic shock, then if PCI is feasible, do it. Otherwise, we go for coronary artery bypass surgery. If there's ongoing ischemia, heart failure, arrhythmias, electrical instability, then of course a PCI should be attempted. If they have severe triple vessel disease and low ejection fraction, then surgery may be the best option. It's not said here, but anyway. Symptom onset between 12 to 24 hours. The patient is still having symptoms, we can consider PCI. Totally occluded CTO vessels supplying the area of the acute myocardial infarction, and it's been greater than 24 hours, just sit and wait. Let the myocardial infarction settle down, bring these patients for stress evaluation and decide what needs to be done. All right, STEMI non-infarct coronary artery. The only time you would intervene in a non-infarct coronary artery would be here. It's class 1 indication in selected hemodynamically stable patients with STEMI and multivessel disease after successful primary PCI. Staged PCI of significant non-infarct coronary artery is recommended to reduce the risk of death or MI. So look at this. This is stage. It is not saying in the same setting. And there are other ones. You can just read it. And let's go to harmful. In patients with STEMI, complicated by cardiogenic shock, PCI of non-infarct artery at the time of primary PCI should not be performed because of the high risk of death and renal failure. Think about it. When we are doing cardiac catheterization, we are giving contrast, and the more contrast we give, the more chances of having renal failure. And you take a cardiogenic shock patient and put them into renal failure, I think we have done more harm than good to these patients. However, if these patients have significant triple vessel disease and their left ventricular function is reasonably good, then a bypass surgery may be a better option than trying to deal with a non-infarct artery, thinking that improving the circulation would improve the overall left ventricular function. That's wishful thinking, but it doesn't always happen that way. Let's move on. STEMI and successful PCI of infarct artery with stable appearing non-culprit arteries. What do we do? If there is cardiogenic shock, yes, routine revascularization of non-culprit is not recommended. If there is no cardiogenic shock, low risk patient with low complexity of the lesion, then yes, possibly we can do a coronary intervention. If the lesion is complex and it is a non-culprit vessel, now let's go to the next slide here. As we can see, we need to look at the amount of myocardium at risk. I mean, that is the key factor. If the myocardial ischemia or jeopardy is less than 10%, medical treatment. The nuclear tests have shown that anytime the myocardial perfusion of less than 10% is reversible, then medical treatment, patients do better compared to interventions. Whereas we also need to look at the complexity of this multivessel coronary artery disease. If there are complex multivessel non-culprit arteries, yes, then it has to be discussed with the heart team, and either we can attempt a stage PCI or send this patient for coronary artery bypass surgery. But if the lesions, multivessels, no, then stage PCI of the culprit artery may be considered. Anytime we need to consider the heart team and also practice-guided medical treatment. Now let's switch gears and move on to non-ST segment elevation acute coronary syndrome or N-STEMI, which are two different categories altogether. But anyway, here are class 1 indications. We need to remember this. In patients with non-ST segment elevation acute coronary syndrome, that is elevated with recurrent ischemia, it is appropriate to consider revascularization, an invasive strategy with intent to proceed with revascularization as indicated. In patients with non-ST segment elevation acute coronary syndrome and cardiogenic shock who are appropriate candidates for revascularization, emergency revascularization may be done to reduce death. Similarly, you can just read this one. Let's move on to the next one. Here are 2A and 3 indications for non-ST segment elevation acute coronary syndromes. You can read this one. I'm just going to read this part, harmful. In patients with non-ST segment elevation acute coronary syndrome who present in cardiogenic shock, they don't have a STEMI, they have a N-STEMI, but they are in cardiogenic shock, routine multivessel PCI of non-culprit lesions should not be done in the same setting. I know we have the oculostenotic reflex. People just want to think they can get it. It probably takes 20 minutes, but it may not work out that way all the time. Now, same thing here put together. If somebody is in cardiogenic shock and refractory angina with hemodynamic instability and electrical instability, immediate invasive strategy, either stenting or bypass surgery should be considered. Whereas a high risk with a gray score of greater than 140 with clinical events, then early intervention within 24 hours may be reasonable. Initially stabilize the patient who are at intermediate risk or low risk, and then invasive strategy with intervention to perform revascularization before hospital discharge. So it depends upon the clinical presentation, their left ventricular function, the coronary anatomy, their pre-existing conditions, and how stable they are in terms of hemodynamics and electrical activity. Now let's talk about left ventricular dysfunction and multivessel CAD. We're talking about a group with a left ventricular ejection fraction of less than 35%, or someone who has a left main coronary artery disease. So we just look at class A. In patients with SIHD, multivessel CAD appropriate for CABG with severe left ventricular dysfunction, ejection fraction less than 35% is recommended to improve survival. So if we are dealing with a triple vessel disease patient with a reduced ejection fraction, the standard recommendation according to 2021 guidelines is to do coronary artery bypass surgery and not stenting. However, some of the more recent reports may have a different view on that one. So let's go look at the left main. In patients with inducible ischemia, significant left main stenosis, CABG is recommended to improve survival. Again, there are more recent studies which show that if the left main lesion is suitable, putting a stent may be as good as doing coronary artery bypass surgery, but based on the 2021 recommendations, this is what is class 1 indication for coronary artery bypass surgery, someone with a left main coronary artery disease. Let us proceed here. Multivessel CAD, proximal LAD. Again, these are all 2B indications. 2B is moderate, 2B is weak evidence. So you can just look through these because they are going to be important if you are having a patient with a similar presentation, someone who has multivessel CAD and someone whose anatomy is suitable for coronary bypass surgery, then you may consider them for bypass surgery. Because from a practical point of view, if you're studying for your board exams, you need to know, as I said, 1, class A, and class 2A, and class 3, harmful. So single or double vessel coronary artery disease. So if you are dealing with 1 or 2 vessels, we're not talking about the left anterior descending artery, and if they have 1 or 2 vessels, and if their FFR is greater than 80, revascularizing these patients can be harmful. So keep that in mind. It could be a board question. Let's move on. So this is a very complex slide, but let's see if we can simplify this. SIHD. Somebody is having refractory angina on medical therapy. If they are having refractory angina, revascularization. If they are not having refractory angina, now we have to decide, does this patient have a left main coronary artery disease? If this person has a left main coronary artery disease, then we have to look at the anatomic complexity. If it is suitable for CABG, then you proceed with CABG, and if not, you can look at the medical treatment or PCI. If the anatomy is not suitable, complexity is not suitable, then coronary artery bypass surgery, or a second 2A indication would be PCI. Then, if the person doesn't have a left main coronary artery disease, they have multivessel CAD, then you anatomy is suitable for PCI or CABG. If the anatomy is not suitable, if they got severe triple vessel disease with very poor distal vessels and reduced ejection fraction, it's kind of a end stage heart problem, then you just treat them with medical treatment. Or if the arteries are suitable, then we want to evaluate if they have ischemic cardiomyopathy. If they are suitable for coronary artery bypass surgery, then it depends upon if the ejection fraction is less than 35% or between 35 to 50%. If it's less than 35, class 1 indication is coronary artery bypass surgery. If it's between 35 and 50, it is 2A indication. Again, if it is not suitable for CABG, a team discussion has to be done. If the ejection fraction is greater than 50% with triple vessel disease, we can either go with, again, they are not class 1 indication, go with class 2 and class 2B, which are equal with triple vessel bypass or surgery, bypass or PCI. Revascularization to improve symptoms. Recommendation to improve symptoms. Class 1 indication is patients with refractory angina, despite medical treatment with significant coronary artery stenosis, amenable to revascularization. I think we have sort of covered this in different ways in the past. Basically, if they have a stenosis, and if that is causing the symptoms, and if there's a significant area of myocardium at jeopardy, then a coronary intervention would be reasonable. It is harmful if the patient with angina but no anatomic or physiological criteria for revascularization, neither CABG nor PCI. So if they don't have an anatomy suitable for PCI or CABG, it doesn't make sense to venture into that path. Older patients, as in all patients, treatment of CAD should be based on individual patient's preference, cognitive function, left ventricular function, their functionality, life expectancy, and a whole bunch of other things. Diabetes patients, I would just look at core 1 indication, patients with diabetes and multivessel CAD with involvement of LAD who are appropriate candidates for CABG should have CABG done with LIMA to the LAD and preferably RIMA to the right coronary artery to improve the longevity, to improve the symptoms, and improve the overall condition. So you can just read through these ones, and I'm just going to go on. We still have a lot more to cover. And people who had previous CABG, we have to understand there's a lot of scarring. All these bypass grafts are kind of stuck to the chest wall and the cardiac tissue. There's more bleeding in redo surgery patients. And also we have issue with finding proper veins or even arteries to bypass. In addition to that, they may have significantly progressive coronary artery disease with multiple lesions, tandem lesions in multiple branches. So it poses a whole new challenge, and that's why we don't have a class A indication. And class 2A is the only one in patients with previous CABG, in patients with LIMA to LAD who need repeat vascularization. If PCI is feasible, I mean, we can do a PCI of like LIMA stenosis at the insertion or consider re-CABG. Someone who can tolerate dual antiplatelet agents, CABG may be the alternative. All right, let's move on. And pregnant women, in pregnant patients with STEMI, not caused by spontaneous coronary artery dissections. So spontaneous coronary artery dissection, which is fairly commonly seen in young females, it is reasonable to perform PCI as the preferred revascularization strategy. This is an extremely difficult situation because you have to use dual antiplatelet agents. Even if you use a bare metal stent still for a month, and that can pose extra challenge. Okay, let's move on to chronic kidney disease. Chronic kidney disease can complicate cardiac problems in every possible manner you can think of. Their hypertension can be an extra burden. Volume overload can make heart failure worse. And the elevated creatinine and all this can have significant effect on clearing of cardiac drugs. So all of these put together, these patients are at a very high risk for heart failure, for arrhythmias, and all kinds of things. Plus, when they go for a procedure or a surgery, their postoperative course could be rocky. Anyway, class 1 indication in patients with chronic kidney disease is a patient with the CKD undergoing contrast media injection for coronary angiography. Measures should be made. That is, we have to protect their kidneys. We can't just indiscriminately inject. There are times when we have been able to do angiograms with like 50 cc's of contrast, because if that's all you need, unless you're doing intervention, and especially if they have complex coronary anatomy, then it's better not to do a coronary intervention and give them 200-300 cc's of contrast, which can make their kidney function worse. Again, in patients with STEMI and chronic kidney disease, coronary angiography and revascularization is recommended with adequate measures to prevent acute kidney insufficiency. That is, we need to hydrate these patients, use appropriate solutions, and monitor their creatinine, monitor their volume status, and hopefully we can get through. And let's look at this no benefit. In asymptomatic patients with stable CAD and CKD, routine angiography and revascularization is not recommended. That should be a no-brainer. So here are some of the things that talks about how to minimize worsening kidney function when we are doing angiography. You can just pause the video and look at these and we'll proceed. Now talk about ventricular arrhythmias. Class 1 indication is patients with ventricular fibrillation, polymorphic ventricular tachycardia, VT, or cardiac arrest. Revascularization of significant CAD is recommended to improve their overall survival. There's no benefit if the patient has a CAD and suspected scar-mediated sustained monomorphic VT. So if the VT is coming from a scar tissue, then revascularizing that patient is not going to change the chemistry of this origin of VT, and that is why it is not recommended. Okay, revascularization in patients with SCAD. In patients with SCAD who have hemodynamic instability or ongoing ischemia despite therapy, revascularization is considered. Routine revascularization is not recommended in patients with SCAD. All right. Recommendations of radial versus femoral approach for PCI. These class 1 indications in patients with acute coronary syndrome undergoing PCI, radial approach is indicated in preference to femoral approach to reduce the risk of death, vascular complications, and bleeding. Stent type, again, stent type depends upon the urgency of the procedure and any interventions or procedures coming up in the first month, third month, 6 months, or 1 year after the stent placement. Again, use of intravascular imaging. These are all 2A indications. You can just read that. In patients with STEMI, routine aspiration thrombectomy for primary PCI is harmful. So keep that in mind. That could be a bold question for you. Let's move on here. Recommendation of treatment for calcified lesions. In calcified lesions, rotational atherectomy can be useful, and it is a 2A indication. For saphenous vein disease, saphenous vein grafts are the most challenging ones. They have a cheesy material, and every time you put a wire or a balloon or inflate anything, all the cheesy material just goes downstream like a shower, and it creates a lot of microemboli. So it is not a very pleasant situation to deal with saphenous vein grafts, but still we can get reasonable results in select patients with previous CABG undergoing PCI of saphenous vein graft. The use of embolic protection device, when technically feasible, is reasonable to reduce the risk of distal embolization. So if we have access to preventing distal embolization, that is something we need to take into account. There's no benefit. You need to watch this one. In patients with chronic occlusive saphenous vein graft, percutaneous revascularization of saphenous vein graft should not be performed. So if there's a chronic occlusion or a total occlusion, it may not be worth trying to reopen that saphenous vein graft. CTO, again, it's a 2B indication. Now, recommendations for patients with stent restenosis. You're all familiar with what you do with stent restenosis. Class 1 indication is in patients who develop clinical in-stent stenosis for whom a repeat PCI is planned. A drug-eluting stent is used to improve the outcomes if the anatomic factors are appropriate and the patient is able to comply with dual anti-platelet agents. You can read the rest of the stuff. Let's move on. We got a few more slides. Recommendations for complex PCI. This is a 2B indication. In select high-risk patients, elective insertion of hemodynamic support such as intra-aortic balloon pump or Impella may be reasonable to support the complex PCI. This is P2Y12 inhibitors, and obviously, all these patients who have stents need to be on dual antiplatelet agents depending upon the type of stent we use. If it's a metal stent, they need to be on for 30 days. If it's a drug-eluting stent, preferably they need to be on for a year before we go for any elective procedures, even though after 6 months we can reasonably stop that and do the procedure and get them back. Of course, during the procedure, we can load these patients with clopidogrel before the procedure begins. One other harmful effect in patients undergoing PCI who have a history of stroke or transient ischemic attack, prasugrel should not be administered. So just memorize that one. Prasugrel, history of stroke, don't give it. Prasugrel, prasugrel, history of CVA or TIA, don't give it because it's increased incidence of intracranial hemorrhage. Anyway, we also have this oral antiplatelet agents, which you're all familiar with. And the good part is it gives all the dosages, which I'm not going to go through, but at least you can pause and watch this one so that whenever you need to look for some reference, this presentation has everything that you need to know about how to deal with coronary artery patients if they have ischemia or if they have symptoms, and what do we do with those findings. Then intravenous, of course, we have absaximab, eptifibatide, tirofiban, and cangrelor. These are all used in the cath lab. Very rarely do we use outside if we think about a lot of clot burden. Glycoprotein 2B3A inhibitors, it's a class 2A indication, and there's no benefit in patients with SIHD undergoing PCI, the routine use of intravenous glycoprotein 2B3A inhibitor. So keep that in mind. And here is a heparin versus low molecular weight heparin and bivalirudin. In fact, when I was doing cardiac cath interventions, we always switched to bivalirudin. We rarely ever use heparin in the last few years. When we are using low molecular weight heparin, we have to understand it has a long half-life. It has to be stopped at least 12 hours before the procedure. Heparin can be used and we can stop that any time. The harmful effect in patients with therapeutic subcutaneous enoxaparin in whom the last dose was administered within 12 hours of the PCI, unfractionated heparin should not be used for PCI and may increase bleeding. That's exactly what I was telling you from the clinical experience. Okay, then we have all these dosages. I put these because you have all the information you need to treat a coronary artery disease patient through this ACC 2021 guidelines, which I think is a great resource for the next 5 years for any practicing fellow, cardiologist, or even an internist. So we have all these different things. You can look at it. And this is PCI. I'm just going to leave this chart and move on because it's too much. And beta blockers. In patients with SIHD, normal left ventricular function, routine use of chronic oral beta blockers is not beneficial to reduce cardiovascular events after complex revascularization. So this is an important point to remember. Beta blockers. Beta blockers, class 1 indication is in patients after CABG. Beta blockers are recommended and should be started as soon as possible to reduce the incidence of clinical consequences of postoperative atrial fibrillation. I followed thousands of heart surgery patients at the Texas Heart Institute in the early 80s, 90s, and 2000s, and I routinely put them on beta blockers, even though many of my colleagues didn't do, because a third of these patients can go into atrial fibrillation. If they do, if they are already on beta blockers, it will keep their rate from going into 180, 200, which will avoid an unnecessary phone call. So beta blockers are extremely useful in CABG patients in terms of reducing postoperative atrial fibrillation causing rapid ventricular response. And recommendations for anti-platelet agents for atrial fibrillation and anticoagulation after PCI. This is again a complex subject. In patients who are going for PCI, they need aspirin and PLAVIX or some other analog, but patients who are already having atrial fibrillation on top of that also have like warfarin or any other antithrombin agents. In those situations, it is recommended that they stay on triple drugs for 1 month, and after that you just use an antithrombin and an antiplatelet agent and drop the aspirin altogether. Smoking cessation. You need to document smoking cessation, weight management, because all of these have procedure codes which can increase your reimbursement. Most people don't understand the complexities of billing an office visit. If you document smoking cessation, you recommend them to have smoking cessation classes or go somewhere, or you document patient's BMI and you make recommendations as far as their diet and exercise is concerned, there is a separate code to add that to your routine follow-up, which can increase your revenue. Anyway, recommendations for cardiac rehab, which we already know, and a lot of these patients, especially those who are going for coronary bypass surgery, have a lot of emotional and psychological concerns, and all these things need to be addressed, and these patients need to be evaluated for counseling, because we used to do that for heart transplant patients. They used to go through complete thorough evaluation of their social and psychological makeup to determine whether they will be able to withstand the stress of cardiac transplant. So ladies and gentlemen, this is a long-winded summary of how to manage coronary artery disease patients presenting with significant coronary artery disease, progressive symptoms, changes in heart function, in the presence of multiple coexisting medical conditions. How do you navigate and decide what is the most appropriate treatment, and more importantly, determine what are the things that you need to avoid doing in these patients to begin with. Thank you so much for your attention, and please do subscribe to our YouTube channel, and please share with your colleagues who can benefit from this one, because this is like a Bible. I have to say this because this is cardiology Bible, because as a primary care cardiologist, and every one of us need to know at every step what is a class 1 indication, what is a harmful indication. Thank you so much.